Dr. Wolf.
Thank you. What if you picked up the morning paper tomorrow and saw the following headline: 50 people died yesterday because they lacked health insurance. The next day, the same headline, and the next as well. This is the average number of people in the United States who, according to a 2004 report from the National Academy of Sciences, die each day, more than 18,000 a year, because they lack health insurance. How should we respond to this unacceptable and embarrassing finding? Not by saying, as President Obama has said, that if we were starting now from scratch, we would have a single payer, but it's too disruptive, or as the health insurance industry said last week, having the public option, it's just an option, would be too, quote, devastating. What could be more disruptive and devastating than being one of 45 million people who are uninsured, from whose ranks come 18,000 people who die each year because of this dangerous status? The real question is, why should we tolerate the fragmented, highly profitable, administratively wasteful private health insurance industry any longer? In this regard, the public is way ahead of either President Obama or most people in the Congress in its distrust of the health insurance industry. In a recent National Harris poll last fall, the following question was asked: which of these industries do you think are generally honest and trustworthy, so that you normally believe a statement by a company in that industry? Only 1 in 14 people, or 17%, thought that the health insurance industry was honest and trustworthy. The only industries that were worse than the health insurance industry were HMOs, 7%, oil, 4%, and tobacco, 3%. The Congress, on the other hand, trusts the health insurance industry and feels compelled to come up with a solution that avoids a big fight with them, not only writing them into the legislation, but assuring further growth of that industry. The Congress wants to believe that the health insurance and pharmaceutical industries will be good citizens and voluntarily lower their prices to save some of the money that is necessary to fund health insurance. Several weeks ago, the collective forces of the health industry promised that they could voluntarily save $2 trillion over the next 10 years. But the amount that can be saved over the next 10 years by just eliminating the health insurance industry and the $400 billion of excessive administrative costs it causes every year is $4 trillion in one fell swoop. This would be enough to finance health care for all without the additional revenues the Congress and administration are desperately seeking. As an example of administrative waste, over the last 30 years or so, there may have been 2 to 3 times more doctors and nurses, pretty much in proportion to the growth of the population. But over the same interval of time, there are 30 times more health administrators. These people are not doctors, they're not nurses, they're not pharmacists, they're not providing care. Many of them are being paid to deny care. So they are fighting with the doctors, with the hospitals, to see how few bills can be paid. That's how the health insurance industry thrives, by denying care, paying out as little as it can. There's no question that we have a fragmented health insurance industry, and it thrives on being fragmented, avoiding any kind of serious, centralized examination or control, which could improve quality, costs, and everything. The drug companies make much more money with this insurance fragmentation because there's no price control. The insurance companies make much more money because they can push away people who aren't going to be profitable, let public programs take care of those patients who are, quote, unprofitable. What the President and the Congress are really realistically advocating, since there is absolutely no possibility of having enough money to cover all people in this country as long as the private for-profit health insurance industry is allowed to exist, is more incremental reform, not national health insurance. It is now 44 years since Medicare and Medicaid. In the interim, there have been many experiments in this country and abroad to try and provide universal health coverage. Other countries have uniformly rejected the private for-profit insurance industry and have adopted national health insurance. There are little experiments going on in Germany and Australia, but mainly it is national health insurance. Is everyone else wrong and only the United States is right? A recent study by OECD, which is the Europe-based Organization for Economic Cooperation and Development, provided health insurance data from its 30 member countries, including Europe, the United States, and others. The latest data showed that 27 of the 30 countries had health insurance coverage for more than 96% of the population, with only Germany having any non-public coverage, 10.3%. The other 3 that didn't have 96% coverage were Mexico with 60.4%, Turkey with 67.2%, and the United States with 84.9%, of which 27.4% was public coverage. In Canada, back in 1970, they were spending the same percentage of their gross national product as we were on health. They also had millions of uninsured people and many of the same insurance companies, such as Blue Cross Blue Shield. They decided to just get rid of the health insurance industry. They had experimented with it in Saskatchewan 10 years earlier, and it worked so well they couldn't wait to do it nationally. So where there's a will, there's a way. There is no way we are ever going to get to having good health insurance for everyone as long as there's a health insurance industry in the way, obstructing care. One more recent experiment abroad includes Taiwan, where in 1995 they said, we don't like the fact that 40% of our population are uninsured. They passed essentially a single-payer plan, and within a few years, 90 to 95% of people were covered. In the U.S., we have had experiments as well, with 7 states having instituted various versions of the public-private combination that this legislation seeks to provide. In none of these states has this worked. Once several years had elapsed with little improvements in insurance coverage, it was back pretty much to where it started, despite initial enthusiasm and short-lived decreases in uninsured. So as we consider what to do, which experiments do we follow? The ones that were successful, all of which, for practical purposes, eliminated the private insurance industry, or the failed U.S. state examples, all of which were built on this industry. If instead of saying that a single-payer program is not politically possible, the President and the Congress need to say, it is not only politically possible, politically feasible, but it's the only practical way national health insurance will ever happen. Anything short of that is essentially throwing tens of billions of dollars at the insurance industry. And if you're afraid of the insurance industry, then you're afraid of doing the right thing, which is having everybody in and nobody out.
Dr. Wolf, almost 2 minutes. You're done. All right. Thank you.
You anticipated my
All right. Thank you. Dr. Woolhandler. Your mic is either not on or you have to pull it closer to you.
Oh, I guess that's it.
That's
now.
good.
Yeah,
Thanks.
Thank you. Well, members of the committee, Mr. Chairman, I'm Steffi Woolhandler, a primary care doctor in Cambridge, Massachusetts, and an associate professor of medicine at Harvard. I also co-founded Physicians for a National Health Program, and our 16,000 physician members support nonprofit single-payer national health insurance because of overwhelming evidence that lesser reforms, even with a robust public plan option, lesser reforms will fail. Private insurance is a defective product. Unfortunately, the Tri-Committee plan would keep private insurers in the driver's seat and indeed require Americans to buy their shoddy products. Once failure to buy health insurance is a federal offense, what comes next? A Ford Pinto in every garage, lead-painted toys for every child, maybe some melamine-laced chow for every puppy. Even middle-class families with supposedly good coverage are just one serious illness away from financial ruin. My colleagues and I recently found that medical bills and illness contribute to 62% of all personal bankruptcies, a 50% increase since 2001. Strikingly, 3/4 of the medically bankrupt had health insurance when they first got sick. In case after case, the insurance families bought in good faith failed them when they needed it most. Some were bankrupted by co-payments and deductibles and loopholes that allowed their insurer to deny coverage. Others got too sick to work, leaving them unemployed and uninsured. And insurance regulations like those in the Tri-Committee bill cannot fix these problems. We in Massachusetts have seen in action a plan virtually identical to the one you're considering. In my state, beating your wife, communicating a terrorist threat, or being uninsured all carry $1,000 fines. Yet despite these steep penalties, most of the new coverage in our state has come from expanding the Medicaid-like programs at great public expense. According to the state's disclosure to its bondholders, our health reform has cost $5,000 annually for each newly insured adult. That's equivalent to over $200 billion annually to cover all Americans with this style of program, or about $2 trillion if you want to do it over 10 years. But even such vast expenditures haven't made care affordable for middle-class families in Massachusetts. If I were to lose my Harvard coverage, I'd be forced to lay out $4,800 for a policy with a $2,000 deductible before the policy paid a penny, and a 20% copayment after that. This skimpy, overpriced private coverage like this left 1 in 6 Massachusetts residents unable to pay their medical bills last year. 1 in 6 unable to pay their medical bills. Meanwhile, rising costs have forced our legislature to rob Peter to pay Paul. Funding cuts have decimated safety net hospitals and clinics. Today, the state announced that health reform funding would be cut by $115 million as of July 1. In 1 week, $115 million. And our state treasurer, Cahill, opined that Massachusetts could no longer afford the reform. That's in today's Boston Globe. As research I published in the New England Journal of Medicine showed, a single-payer reform could save about $400 billion annually by shrinking healthcare bureaucracy, enough to cover the uninsured and to provide first-dollar coverage for all Americans. A single-payer system would also include effective cost containment mechanisms like bulk purchasing and global budgeting. As a result, everyone would be covered with no net increase in U.S. health spending, but these savings are not available unless we go all the way to single-payer. Adding a public insurance plan option cannot fix the flaws in Massachusetts-style reform. A public plan might cut private insurers' profits, which is why private insurance companies hate it. But their profits account for only about 3% of the money squandered in bureaucracy. Far more goes for marketing to attract healthy, profitable members and demarketing to avoid the sick. And tens of billions are spent on the armies of insurance administrators who fight over payment and their counterparts at hospitals and doctors' offices. All of these would be retained in a public plan option. And overhead for even the most efficient competitive public plan would be far higher than Medicare's, which automatically enrolls seniors when they turn 65, disenrolls them only at death, deducts premiums automatically from Social Security checks, etc. Unfortunately, competition in health insurance involves a race to the bottom, not the top. Competition in healthcare is a race to the bottom, and a competing public plan would be pushed to the bottom. Insurers compete by not paying for care, by denying payment and shifting costs onto patients or other payers. These bad behaviors confer a decisive competitive advantage. A public plan option would either emulate them, becoming a clone of private insurance, or simply go under. A kinder, gentler public plan option would quickly fail in the marketplace, saddled with the sickest, most expensive patients whose high costs would drive premiums to uncompetitive levels. In contrast, a single-payer reform would radically simplify the payment system and redirect the vast savings to care. Hospitals could be paid like a fire department, receiving a single monthly check for their entire budget, eliminating most billing. Physicians' billing would be similarly simplified. 8 decades of experience teaches that private insurers cannot control costs or provide American families with the coverage they need. A government-run clone of private insurers, called a public plan option cannot fix these flaws. Only single-payer insurance can. Thank you.
Thank you. Dr. Goodman.
Thank you, Mr. Chairman, members of the committee. Every single healthcare system in the world today faces 3 fundamental problems: cost, quality, and access. In our own country, healthcare spending is rising at twice the rate of growth of income and has been doing so for 40 years. If that continues, clearly healthcare will crowd out everything else that we care about. But we are not worse in this respect than other developed countries. Over the last 40 years, the real rate of growth of healthcare spending per capita in the United States has been just slightly below the OECD average. We have quality problems in this country, but despite those problems, we appear to overall deliver a higher level of quality than just about any other country. We are number 1 in the world, for example, in survival of cancer patients. We have access problems in this country, but I think we do better than just about any other country with a heterogeneous population. The U.S. population gets more preventive care by far than Canadians, for example. Americans get more mammograms, more pap smears, more PSA tests, more colonoscopies by quite a considerable margin than the Canadians do. Low-income white Americans appear to be in better health than low-income white Canadians. The minority population of the United States seems to do better in our healthcare system than the Inuits or the Crees in Canada, or the Aborigines in Australia, or the Maori of New Zealand. Now, what about the proposals being considered by Congress right now? What will they do for the problems of cost, quality, and access? When Peter Orszag was head of the Congressional Budget Office last year, he examined all of the major proposals that candidate Barack Obama was making to lower health care costs: preventive medicine, coordinated care, electronic medical records, evidence-based medicine, and so forth. And what the CBO concluded was that none of these proposals would make any significant difference in rising health care costs. On the other hand, if we spend an additional $150 billion a year on health care, that almost certainly will contribute to health care inflation, making the problem of cost worse, not better. What about the problem of quality? Well, there's nothing that I have seen in any of the proposals being seriously discussed that would appear to make any significant difference in the quality of care that Americans receive. But on the other hand, if we create an artificial market in which insurance companies are forced to community rate their products to millions of people and do so annually, they will very quickly discover that they want to seek to attract the healthy and avoid the sick. And once enrollment occurs, they will seek to over-provide to the healthy and under-provide to the sick. That's good if you're healthy. It's not going to be good if you're sick. So we're setting in place an artificial market in which the incentives to under-provide are going to be very strong. And the more competitive that market is, the more insurers will be inclined to act on those financial incentives. What about access? Well, again, we do have access problems in this country, no doubt about it, but we're not going to solve those problems by putting millions of people into Medicaid and encouraging people with private plans to drop their private coverage and enroll in Medicaid, as a number of the proposals now would do. Basically, that's what Massachusetts did. Massachusetts cut its uninsured rate in half, and it did so by putting thousands of people into Medicaid and thousands more into private plans that are paying Medicaid rates. And those people are finding they have a difficulty in obtaining access to care. A study just last month concluded that the wait to see a new doctor in Boston is more than twice as long as it is in any other U.S. city. And for Massachusetts as a whole, the number of people who go to hospital emergency rooms today for non-emergency care is as great as it was 3 years ago before the Massachusetts health care plan was started. Medicaid is not a solution for the problems of the uninsured. The cancer studies show that in terms of delays in treatment and delays in detection, being on Medicaid is only marginally better than being uninsured. And when people drop private coverage to join Medicaid, they're leaving a plan which allows them to see almost any physician, go to almost any facility, get care fairly promptly, and go into a system where there are long delays and where there are much fewer choices. So the real danger, Mr. Chairman, is that we're about to pass legislation that will not only not lower the cost of care, but will make it higher, that will not improve quality and may actually cause quality of care to go down, and may even make health care less accessible for millions of people. Thank you.
Thank you, Dr. Goodman. Thank all of you.